Well, thank you for coming back. It's still Tuesday, the 19th of May. Now, there's a few countries I want to review today, largely the UK and the US, but a few others as well, because it reveals things about the virus that I believe everyone needs to know and things the world needs to be discussing because they're useful. So let's dive straight into that. Now, Latin America, South America, is still remarkably concerning. Things are accelerating there quite dramatically. St. Paul, Sao Paulo, 3,000 deaths in the city officially, and the mayor said the health system will be overwhelmed in a few weeks. The trouble is, in Brazil, the peak is probably about a month away, so it's unclear what's going to happen, and basically, I'm afraid it means that more people are going to die than need to die. So it's a remarkably concerning situation there. It's not looking good, to be quite honest. India, I've been concerned about India, Bangladesh, Pakistan all the way through. 8 weeks into the lockdown now, the economic difficulties I've been told about there are extreme, including actual people going hungry. The official cases increase, the deaths are increasing. But of course, testing is still very slight in India. But people are making a lot of attempts. So, for example, Paul sent me this picture in. I'm pretty sure it's Chennai. So what they've done, all the vegetable wallers here, they've been put on these separate bus bits so the bus normally goes down there, I guess. So, they're well separated and there's lots of fresh air. So actually a fairly safe way to conduct a market. So it's good to see that these kind of initiatives are being taken in India, despite the lack of testing and what is challenges to the healthcare system. Now, this next bit's quite important because it relates to the clinical features. And we need to know the clinical features because it's only when we know the clinical features that we know when to isolate. And remember, as I've said many times, and you know this by now, the only way out of this lockdown is test, trace, isolate, because we can't yet vaccinate. So we need to be able to recognise the features. Now, the UK government's recently changed its mind on, well, it's added loss of smell. So we'll just look at what they're saying for diagnosis for staying at home. So high temperature means you feel hot to the touch on your chest or back. You do not need to measure your temperature, but useful if you can. So I do advise having a thermometer in the house. New continuous cough. This means coughing a lot more. This means coughing a lot for more than an hour or 3 or more coughing episodes in 24 hours. Right, so if you're coughing a lot for an hour, you have 3 or more coughing episodes in 24 hours. And of course, some people do anyway, so this is a different cough. And it's usually a dry cough. So that's been the situation for weeks. Now, this has been added as of yesterday. Loss or change of your sense of smell. And smell goes with taste because you probably remember that in your tongue you only can taste sweet, sour, bitter, salt and that chili flavour. I can't remember what you call it. Most of the nuance in taste actually comes from smell. So when you lose your sense of smell, you lose a lot of your sense of taste as well. So things smell differently or loss of sense of smell is now a grounds for quarantine. So if you lose your sense of smell all of a sudden, we should assume that is COVID-19 and isolate ourselves for 14 days, just as if we had a continuous cough or fever. Now, why is this coming now? Now, this is interesting because I got an email back in early February from a colleague in Iran saying a lot of people are reporting loss of smell. And I thought, well, that's a bit funny. Loss of smell. Anosmia is a medical term when people can't smell. But it's turned out to be true. So on the 20th of March, we did a report with the ear, nose and throat doctors reporting on this. So it's kind of been known about for a while, but the government just seemed to act on it recently. So the government scientist says it does increase the sensitivity infection a little bit. So it looks like they've come to the party late on this. I must say, for the calibre of scientists the government is supposed to be employing, sometimes they're a little bit late to the party, to be quite honest. The scientific and medical advice the government has received is certainly open to question, given the calibre of the people that are supposed to be doing this job. That they've only just done this is disappointing, and we'll see why it's disappointing in a minute. Now, an app like on the Isle of Wight, that could be another 2 weeks. So basically, we're depending on these clinical grounds for some time yet. ENT Doctors said just a minute, loss of smell could mean you're infected, could mean you infect other people. Back on the 20th of March, King's College London group reported this clearly from large-scale data on the 1st of April, and yet the government acts on it on the 18th of May. I must say I'm a bit stuck and certainly a bit disappointed. So this data from King's College is coming from the COVID symptom tracker. And that's on your phone, so that's a really good thing. I report into that every day to report my symptoms, or lack of them, thankfully, so far. But do put that onto your own phone as well. It doesn't mean it's tracking you anyway, it just means you're reporting, and that's where a lot of this information's come from. So it's the King's College London, in collaboration with Zoe, and Professor Tim Spector is in charge of that. And about at the moment there's 3.6 million users. Now that is a good sample size. That is very good. And from that, at the moment, they estimate that in the UK today, there's 250,000 people with symptoms, with COVID-19 symptoms. So this is still alive and thriving in the UK. Now, 59% of people who lost their sense of smell, indicating they may have COVID-19 infection, subsequently tested positive, confirming they did. But only 18% of those who lost the sense of smell tested negative. So most people who lost the sense of smell, by far and away the majority here, 59% to 18%, lost it because they were infected with COVID-19, indicating this is a useful clinical indicator. And because the government has been so slow to act on this, the King's College London group have estimated that an extra 50 to 70,000 cases have been missed. And because this tends to occur more in the young, and perhaps even more in young women, the very people that are likely to get few symptoms, then that means that these people who didn't realise, because the government didn't tell them because its scientists didn't tell them, that you lose smell, they carried on with their normal lives and infected, who knows, 70,000 people could infect tens of thousands, hundreds of thousands of other people. So really, for the time for the government scientists to get their act together. I'm glad they have, but it's a bit late. So more young people are likely to lose smell, and younger women are likely to lose smell as well. So it seems to be younger people in general, but younger females particularly, perhaps. But the data's not clear on that yet. Virus is causing some sort of inflammation in the olfactory nerves. Now, the olfactory nerves are these nerves that go from the nose up into the brain, taking the sense of smell into the brain. So they seem to get inflamed. Doesn't seem to be the nerve cells themselves so much as the cells around about the nerve cells, but that nerve gets inflamed and doesn't work for a couple of weeks. That seems to be the bottom line in most people. And the COVID-19 symptom tracker app shows that asomnia, that is inability to smell, is a stronger predictor of coronavirus than fever. Interesting. Indicating that this anosmia is often the first feature. So loss of smell is often the thing that happens first. So we need to have a high index of suspicion for that, because as we've seen, many of these people tested positive. Now, the King's College London group has collected data from 400,000 people reporting one or more symptoms just in a small period. So much more data to come from this very large study. And all the work I've read from this study indicates it's a very high quality survey. I'm actually quite impressed with the scale of it, 3.5 million people. So this is just a 5-day period. 5-day period. So what were the clinical features in order? Right. The most common presenting feature was persistent tiredness. Atypical tiredness. The person just felt exhausted and had to go to bed. Mental tiredness and physical tiredness both. Both of those occurring. 53% of people that reported symptoms had this persistent undue fatigue. Fever or persistent cough was quite a way down at 32% in the UK. 28% had chest pain, unpleasant, and 29% had a persistent cough, a cough on its own. Persistent cough and fever was 32%, not a lot more to be quite honest. 28% reported shortness of breath. Hoarse voice was 24%. Loss of smell 18%, often an early feature and more common in younger people. Anorexia means not hungry, skipping meals, 16%. Diarrhea, 16%. So quite a lot of people having gastrointestinal features. Confusion and altered mental status, 14%. Now they didn't say, but I assume that's more common in the elderly. But they didn't say. Abdominal pain, 13%. And fever on its own, without cough, 10.5%. So that is good quality data of the clinical features, in order of which clinical features people suffer from most. And that's based on a large sample size, 400,000 people. So persistent fatigue first, fever and cough together, chest pain, persistent cough on its own, shortness of breath, hoarse voice, loss of smell, anorexia, diarrhea, confusion, abdominal pain, fever. In that order as the most common symptoms. And another reason it's so important to know this now is in the UK, anyone can have a test over the age of 5. You can just book it and drive in for it. So anyone who loses their sense of smell should self-isolate, book a test, hopefully go for the test the next day, hopefully get the result back fairly quickly, hopefully within 48 hours. If they're negative, they can return to normal duties. If they're positive, they will self-isolate for the fortnight. So wherever you're watching in the world, important to realise that if you lose your sense of smell, you should isolate. That's one of the ways we're going to prevent the spread of this disease. Trace, test, isolate, because we cannot yet vaccinate. Now, this constant issue of dying with or from COVID-19. So a lot of people have said at various times that a lot of the people that were dying with COVID-19 just happened to have COVID-19, they were going to die anyway. Is that true? Well, the Office for National Statistics has produced firm data to answer this question now. So people dying with or from COVID-19. And this data is based on the 1st of March to the 30th of April. Over 38,000 deaths involving coronavirus. Now, 95% had COVID-19 assigned as the underlying cause of death. 95% had COVID-19 as the underlying cause of death. In 90% of cases, the person who died from COVID-19 had at least one pre-existing condition. So that's slightly different. We'll come on to that point. But this is saying that 95% of people who had COVID-19 at the time of death, the doctors who filled out the death certificate said that was the underlying cause, that was the main cause. So in other words, 95% of people are dying from COVID-19 disease, 5% are dying with COVID-19. So 5% of the deaths, the person would have died anyway. They just happened to have COVID-19 around about the time of death. But 95%, it is the cause of death. So it's reasonable to assume that had that person not caught COVID-19, they would live for weeks, months, years, or decades more. And the Office for National Statistics, just over 90% of cases, a person had at least one underlying condition, diabetes, hypertension, heart disease, chronic obstructive pulmonary disease, whatever it was. Dementia is a common comorbidity. So this also means, of course, that 10% of people were previously healthy. Don't forget that. But it's useful to have this information. Now, the United States, interesting things going on. Vaccine in Modena, Massachusetts. Moderna's the company, I think. Now, 8 people have been given 2 doses of the vaccine each. So 16 doses of this new vaccine developed in Massachusetts have been given. 8 people getting 2 doses each. And the news is encouraging. These people have been given 2 doses of the vaccine. And of course, the vaccine acts as the antigen, just like the virus does. And that is what stimulates the body to produce antibodies. The antibodies are produced, the immune proteins. And it's the antibodies that eliminate the antigen. But of course, in this case, the antigen was not a virus. The antigen was a vaccine. So hopefully they don't get sick. But it's still the same antibodies. So when the real virus comes, if the real virus comes, then the antibodies are all there, ready, primed, guns locked and loaded. It will attack the virus and kill it straight away, hopefully before the person gets any clinical features. And the good news is these antibodies that neutralise the antigen were found in all 8 of these people. Does this mean to say these people will be immune to COVID-19? We have no idea. Is it likely, in my opinion, these people would now be immune to COVID-19? Yes, it is. But it's only a small sample size. But it's promising. And what else was promising is the safety profile was similar to previous vaccines. So it's looking like it may be safe and usable, but again, very small sample size. And the antibody levels, the amount of antibodies, the amount of foot soldiers to fight the virus generated, were similar to the amount of antibodies recovered from patients who'd recovered from COVID-19. So if you take someone who's been vaccinated, take their antibody levels, they've got so many antibodies, get someone who's had coronavirus, take their antibodies, they've got roughly the same amount of antibodies. And of course, that would also mean, in theory, that the people who have been vaccinated could give plasma to people who are acutely ill as well for this passive immunity we've thought about on previous videos. So it looks encouraging, but phase 2, that was the phase 1. Phase 2 trial will involve 600 people. That's going to start soon. Phase 3 will involve thousands and will start in July. Will it protect against the disease? Looks like it, but we don't know yet. We don't know. Now, I have been criticised for getting political. If I am, it's inadvertent. I don't mean to be. But there's things that I'm only interested in politics as it affects human well-being. And President Trump has said the WHO needs to commit to substantive improvements. And I agree. But I also agree that many of the world's leading experts work for the World Health Organization and need to be coordinated in some way. So it looks like President Trump is saying, get your act together, 30 days, otherwise no more money. So I'll leave you to make what you want of that. Now, this was interesting. CDC, based in Atlanta, Georgia, plans a huge study of antibodies to track coronavirus spread. So the Centre for Disease Control and Prevention is starting a nationwide antibody study in 25 metropolitan areas round about the country. Now, what they're doing is they're taking blood from blood donors, and they're going to start doing this in June or July. And they're going to take tens of thousands of them, of blood samples. Now, this is good because they're taking tens of thousands of them. But my question would be, are blood donors a representative sample of the whole country? In my view, it would be better to take a much smaller sample size but ensure it was genuinely random. So a sample size that was genuinely random of 5,000 people from around the country, even somewhere as big as the United States, will give very, very good data. Tens of thousands is good, but it's not a random sample. Now, I don't know who's giving blood in the States at the moment. Are they more or less likely to be infected with COVID-19? Don't know. I assume they do know that and can account for it. Anyway, good that it's in different parts of the country. Good that it's starting soon, although July's a bit of a way off. Tens of thousands is good. And they're going to look for the amount of the antibodies, and that should give an accurate percentage of those that have been exposed to the virus, therefore have antibodies, in different parts of the country, and we can expect accurate data. Although in the last few days we have looked at quite a few smaller scale studies that have looked at this, typically finding infection rates of 5 to 10% so far, indicating we're still near the start of this pandemic, because we're going to need 60% or more for good quality herd immunity. Right, so they've selected sites to give a broad geographical distribution. I'm sure they can do that very well throughout the country. Now, China. Now, the American delegation to the United Nations said a member state has not been completely transparent. They didn't say who they meant, but I seem to be talking about China at the moment. Now, again, I don't want to get political. Whatever I say about this, I get slagged off for it. But China covered this up at the start. We know that. Dr. Lee is proof of that. But since then, okay, they jiggled around with the way they count the testing once or twice. But to be fair, way back in early February, I remember reading reports where the Chinese authorities said they didn't know how accurate their numbers were, but they knew they were an underestimate. What is disappointing is they don't seem to have updated those numbers very much, although they did update the death rate by 50% about a month ago, wasn't it? So, bad start, good follow-up is my conclusion, based on very little evidence, but it's the impression I get. You can have your own views of that, and if you want to criticise me for mine, that's absolutely fine. We know they started badly, but they've done some good things since then. The United States is criticising the World Health Organization with great justification, it has to be said. The World Health Organization has been immensely disappointing in this. But that doesn't alter the fact they have the best people working for them. So I think we have to separate the organisation of the World Health Organization from the expertise of the individuals working for them. Now, China has pledged $2 billion for developing countries to help them with the COVID-19 pandemic. And Chinese hospitals are pairing with 30 African countries. Now, this is very encouraging. Schools have been doing this for a long time. My hospital does have some links with Tanzania, and not that big links. It'd be great to have better links. But this is good because it personalises relationships, and individual nurses and doctors and technicians get to know each other in reciprocal hospitals. So that's good. So Chinese hospitals are pairing up with African hospitals in 30 countries, and China has dispatched medical teams to various parts of the world. Now, you could say that's propaganda if you want to be cynical, but I really don't think this is. I think if there's personal relationships there, then that's got the potential to greatly help in many African countries, because, as you know, I'm terrified that there could be a very high case and infection fatality rate in many African countries. Need for complete international overhaul. Basically, everyone's been saying that, and Dr. Tedros nodded his head on that one. He agrees with the Americans that we need this overhaul, and the Chinese. Some might think he's part of the problem, therefore needs to be overhauled, but he agrees with the principle. As do Australia and South Korea, who are very, of course, reputable governments. And finally today, 140 world leaders call for a people's vaccine. I kind of like the sound of that, people's vaccine. Mandatory worldwide sharing of knowledge. 140 world leaders, of course, called for this. I mean, that's most of the countries in the world. I don't know. I think there's about 180 countries in the world or something. Just depends if a lot of rich, important ones are missing. I'm not sure. Mandatory worldwide knowledge sharing. And this, to some extent, is happening. I've been delighted to see that most of the journals, which are often subscription journals, have been making all the COVID-19 material available freely. It saved me a fortune, apart from anything else. If you had to subscribe to all of these journals, it would be very expensive. So I'm glad to see that that's been put in the public domain. My own personal writing and work I put in the public domain as much as possible. So I really agree with the principles of that. We need a global equitable distribution plan for diagnostics, drugs, expertise, vaccines, therapeutics, free at the point of need. That's the aspiration with 140 world leaders. Let's hope this comes to fruition, because it's a common human problem. Right, I've got a few very important people to show you now. They are people that watch my videos, therefore are important. There we go. So this is Margaret in Queensland in Australia. So delighted to see you are watching, and also taking vitamin D, Margaret, in Queensland. Let me think. That is northeast Australia. Thank you for watching, Margaret. And this is Maria in the US. Now, this is one of my old anatomy videos. Well, it's not that old. It's just when I've got a series of anatomy and physiology videos, and glad to see that Maria's made her own diagram, so she can learn about the left atrium and the left ventricle, and the right atrium and the right ventricle, and the aorta and pulmonary arteries, and yeah. So feel free to visit the site and draw your own diagram of the heart. And Maria, I believe, is a vet or veterinary student. So amazing that animal hearts are remarkably similar in many ways. This is Marlena in Georgia. Can't see her very well, but I'm glad she's wearing face covering, and indeed eye covering. Very good. This is Martin watching in Germany. So glad to see you're watching in Germany, Martin. I hope my English is clear enough to understand. Germans normally speak excellent English, so I'm sure it's not a problem. Thank you for watching in Germany. And this is Mary. Now, I can't remember where you're from, Mary. My apologies, but I do know you're across the pond in the US of A. So great to know you're watching in the States. Looks like you're in some sort of surgery there. There's a thing for heighten. You must be a nurse or a doctor or something. Some sort of surgery picture there. Anyway, glad to see you watching. Thank you, Mary. Now, this team of fine-looking men is Matt, Brandon, Andy and Bill. And Joe. Sorry, Joe, nearly forgot you, mate. And they're in Florida. So glad to see the team is watching in Florida. Matt, Brandon, Andy, Bill and Joe in Florida. Thank you, gentlemen. This is Miguel in Barcelona, and I don't know the name of the dog, but he looks cute. Anyway, thank you, Miguel, for watching in. Looks like a sunny Barcelona. And now this team of workmen are just having a short recess here. Mike and his crew in Czech Republic, and they're making up sanitizers for surfaces. So very useful work, gentlemen. Is there a lady there? Yes, there's a lady there. So lady and gentleman, very useful work, and thank you for sending that in from Czech Republic. This is Mike Tang, who watches in Singapore. Great to know people are watching in Singapore, Mike. Thank you for watching. This is Myra, who is in Vermont, which is the, let me think, northeast of the state, isn't it? Rural state of Vermont. And dog as well, whose name I don't know. But thank you for watching, Myra. Good to know you're watching in Vermont. And this is Natalie in Trinidad and Tobago. I've had a few people send pictures in from Trinidad and Tobago. And I'm pretty sure this is a Mum's Day thing from her children. So that's a very warming picture to see from Natalie in Trinidad and Tobago.